Thank you, Dr. Durham, for that eye-opening and heart-wrenching presentation and showing us how to use stories to improve our work in patient safety and our teaching in patient safety. So, greetings to everyone. Thank you for sticking around for our last presentation, and I know you won't be disappointed. I'm from the University of Alabama at Birmingham, and I'm the co-investigator with Mary Delansky on the ARC conference grant. Speaking of the Agency for Healthcare Research and Quality, they've helped fund most of the speakers for this conference. I have the honor of introducing Patricia Mcgowan. She is the was the Chief Operating Officer and Senior Vice President of Programs at the National Patient Safety Foundation and is now the Vice President for Safety Programs at the Institute for Healthcare Improvement. She has a wide variety of leadership roles in education, outcomes research, clinical decision support, and marketing in successful startup and established medical device companies focused on safety innovation. Patricia serves on numerous national interprofessional committees and task forces related to patient and workforce safety, and is a certified professional in patient safety and a recipient of the American Association of Critical Care Nurses Lifetime Membership Award. Please join me in welcoming Patricia Mcgowan.
Thank you so much. Hello, everyone. Hello, good afternoon. Connecting the dots. I have to apologize, first of all. I didn't bring gum. The second thing I have to apologize for is that you heard the words National Patient Safety Foundation, and I know you're thinking Lucian Leib Institute, because that's our think tank. And you heard IHI, and I know you're thinking Dawn Berwick, and you're saying, how did we get stuck with her? Well, I hope that we'll enjoy our last hour together. This has been a magnificent meeting in my mind. And Mary called and said, can you come and connect the dots? It's really hard to connect the dots when a meeting is not even started yet and a few months before a meeting. But I'm going to do the very best I can to communicate some things that I think are very meaningful in terms of patient safety and how we can accelerate safety. And I hope you leave here with your own dots that will be meaningful for you and all of those who you work with, and more importantly, all of those who you educate and bring into our next generation. Now, I was actually going to start off my talk with that 99.9% good enough video. And Carol and I actually met each other at the sign-in booth, and we decided to have lunch, and it was fabulous. What a great job she did. But I learned I should not start my talk with the same video that she was going to start her talk with. So that's always a good thing. It's always a good thing to have happen when you're preparing for meetings like this. Now, I wanted to tell you that in terms of connecting the dots, what I will try to do is weave in much of what we've talked about this week so you can move forward in terms of defining and executing on your own priorities with respect to QSEN, and how to reactivate and re-energize those priorities, and also your will, because will is so critical in terms of ensuring that we leave here with nothing less than a commitment to freedom from harm for patients, families, visitors, and the workforce. And I'd like you to share some stories with you. You work at the NPSF, the phone rings every day, you get all kinds of stories, particularly about things that have gone wrong. I'm going to share some stories as we walk through this session today and bring this wonderful meeting to a close. So I mentioned that we connected our dots in a merger. It's a month old right now. In between, we had our annual meeting at NPSF. So we've been a little bit busy, but our goals have been to really create systems of safety that are across the entire continuum of care and that are global in nature. And both NPSF and IHI actually brought a lot of very complementary assets together in order to do it. And I was thrilled to hear all the conversations about the IHI and the open school. And I promise you, I'm going to be really focused in on this and how we can help ensure that the open school program can continue to serve you even better, along with other things that we have in our wheelbox in the present and also in the future. Our mission at NPSF is on this slide, and these are in your deck, but I just want to emphasize on the right-hand side of the slide, when we updated our strategic plan last fall, we agreed that we were going to focus on advancing patient safety as a public health issue, establishing patient and workforce safety as a leadership core value, and ensuring that the workforce is skilled and capable in patient safety. And there'll be some threads that you'll hear throughout this conversation today, and I'm going to jump past this slide in the interest of being able to hopefully leave you with something richer than what an organization does. I'll answer any questions you have at any point in time. Otherwise, when I got invited, one of the things that I always do is think about where I'm going and what's special about where I'm going to give talks. So I want to talk for just a second about the magnificent Frances Payne Bolton. How many of you know about this wonderful woman? Okay, you're probably all from the School of Nursing in Case Western Reserve. But let me just share a few things about Frances. Frances was actually Ohio's very first congresswoman. She supported education, initiation of important initiatives related to improving health, and was an avid supporter of nursing. The school truly deserves to have her name in front of that. And one of the things that I found as I was researching her, and she was not a nurse, by the way, but she did all kinds of kick-butt things to advance nursing, and also men in nursing, by the way, if you look at her history. I love this quote: "You must give something to someone to be happier, especially when that gift is your own time and strength." And sometimes I know we want to give up or we get frustrated, but in this room are leaders and people who are critical, absolutely vital to ensuring that we are accelerating the safe care of patients and the safety of that workforce. And you are putting in exponential amounts of strength and time in order to do that. So I wanted to share a little bit about Frances. And on another note of magnificent, we get media calls at NPSF just about every day. Sometimes we get tons of them. We always know when something interesting might have happened related to patient safety, because the phone rings, and we've had one physician who has been our president and CEO, and I've been the nurse, and everyone else is non-clinical. So typically the media calls get punted to one of us. I happen to get the ones that are nursing related, I get the ones that are technology and device related, and a few other ones that aren't so exciting for my colleague, or if she's traveling, that I have to address. So here's an example of a call that we got a few months back. I'm a journalist, and I want you to tell me the top 5 errors that nurses actually make. Okay, so how many of you think this is the kind of question that I was all jumping up and down and excited to answer? I wasn't, and I think you know the reason why. But I told our PR lead at NPSF, I said, how about you do this? How about you go back to that reporter and tell her that I will speak with her if we flip the question, and if I can talk to her about the top 5 things that nurses do to ensure that care is safe. And by the way, when you ask her to adjust the question in such a manner, remind her that the vast majority of errors that occur in healthcare do not occur because of a bad person or egregious intent. There are tons of contributory factors, many which have already been connected and discussed in more detail here today. So we actually had the interview, and the reporter really enjoyed the conversation. And you have to be really careful when you talk to reporters, because they'll take things right out of your mouth and they'll spin them however they want to. But I think it was a real educational moment for her. And this is something I'm sharing with you, not because of me, but because I think we are all very well positioned to be able to talk about how nurses are leading safety and are really at the cutting edge of ensuring that we are accelerating that progress. Now, I want to talk to you a little bit about patient safety as a public health issue. And Carol brought up this point earlier, just a little while ago, that we're at a point where, despite the progress that we have made in safety and quality, preventable healthcare harm remains unacceptably frequent. And she quoted statistics that range from a low end of 44,000 to about 440,000 deaths in some of the recent publications. And all the research geeks are all arguing about whether or not these numbers are right. But let's just settle at the midpoint with one of the publications that recently came out that said 250,000 people die in this country because of preventable healthcare harm. I don't have a picture of Arlington National Cemetery to show you, but we're in Chicago. So how many of you live here in Chicago? Okay, all right, let's put this in perspective. Every year, we are taking out 10% of the population of Chicago if we just use that 250,000 mark. And by the way, I'm not sure those numbers are too high. I personally think they're a lot higher because we don't have good ways to measure death from preventable healthcare error. And we're looking at death, yet look at the complications that occur because of preventable healthcare error. And think about the fact that we don't even have any meaningful ways to track this right now in the non-hospital setting. So I just wanted to make that point and tell you that we've been working on some convening sessions of experts. We wanted to understand the state of patient safety 15 years after the publication of To Err is Human. And one of the first conclusions was this whole debate of have we really gotten any better? And there was a lot of debate in the room. We had people on the original IOM task force, including Lucian Lieb, who's one of the co-chairs, Don Berwick was there, and we had up-and-coming folks who are real leaders in patient safety. And I want this to be one of the most important messages that you take as you leave here today, and you've heard it from other people. We have been reacting in very piecemeal ways to safety and quality issues in healthcare. And we have made good progress in many respects because of that. But we are not attacking what the foundational needs and opportunities and requirements are to really accelerate and reduce harm to patients and families and our workforce. That requires a total systems approach. I'm going to talk about those threads in the time we have left together today. And most of the initiatives that this expert panel agreed we had to focus on included culture, leadership, teamwork, and patient engagement. None of those probably come as surprises to you. We just issued in March, how many of you recognize Patient Safety Awareness Week in your academic institutions? Okay, I want to see 100% of hands. I'm going to come back next year just to ask this question. I want to see 100% of hands go up in the room. Every year, Patient Safety Awareness Week occurs in the second week of March, and we have some fabulous academic nursing programs that use this week. They actually turn it into a month in some cases to really help their students be very focused on raising awareness and working on projects and being able to spread knowledge and understanding throughout their academic institutions. But we issued this call to action that we need to address preventable healthcare harm as a public health crisis. And so now our work is focusing in on how we do that. And again, I'd be happy to come back at some point in time and give you an update on what we're doing that we're trying to impact at the national level so that we are able to address this constant fear that people have of going into the hospital and worried that they're going to come out or never going to come out at all again. We've got to deal with it as a public healthcare crisis, and this call to action, like everything I will share with you today, is freely available on the NPSF website. It might be a really interesting project for some of your students to think about this in more detail. So let's talk about error and harm. I have a question, couple questions. How many of you in this room have either personally or within the context of your family or loved ones been impacted by a preventable healthcare error? Raise your hand. Okay, I'm going to just do a quick estimate here and say that at least 90% of the hands of this room have gone up in the air. I have another question for you. Might be a little bit harder for you to want to raise your hand on this one. How many of you in your course in academia, in faculty, have actually been involved in the care of a patient when a preventable error has occurred? Okay, this is looking like about 50% of people. How many people in this room have never taken care of patients? Let me just get a baseline. Okay, so I'm looking at maybe less than half of you who raised your hand to that question. I told you we get a lot of stories at NPSF. I'm going to share a story with you about something that happened to a nursing faculty member. She was teaching in the classroom and overseeing students in the clinical setting like many of us do, and she was overseeing a student draw up an IV medication that was going to be administered to an adolescent that has a chronic health disease. And there was perfectly good things that happened. Perfectly great technique, drawing up the perfect amount of medication, administering it in the right way, going back to document it in the proper manner. However, that very perfect process had one flaw in it. It was the administration of a look-alike, sound-alike antibiotic. So this is a faculty member who's in the situation where they're overseeing this error, this preventable harm. I was the faculty member who oversaw this very imperfect experience. I was the person who did it. And so I used to be doing the things that you're all doing on a regular basis. And I want to talk to you a little bit about what was going through my mind then. First thing, obviously, was a code brown, which many of you know of, where your bowels just suddenly are ready to let loose. But what kept me up then and for a long time thereafter were the following things. The immediate concern was there any physical harm to my patient? I stayed at the bedside, I dispatched the student to get the nurse manager, we get the physician that came to the bedside, and in fact, that patient did not experience any physical harm. What was also on my mind despite that, however, was punitive action. What's going to happen to me? And sometimes you don't want to say it's all about me first after the patient is safe. But I was very worried about what would happen to me. I was overseeing a student in a clinical setting in which I also worked. So I had this double fear that I was going to be dinged as an employee and as an honorable guest, a faculty member who was invited into this setting. Incident report. Had a great time sitting down with the nurse manager and filling out an incident report. Never had been taught how to fill out an incident report. Suddenly, the person who was the perfect student in all of my classes and all of my years of education, including in my School of Nursing, class president, did everything right, the ideal child, suddenly had this incredible blemish of imperfection on them. And that also was something that really tied into, all of these things tie together, because what was really on my mind was, I got to get out of nursing. I stink. There's no excuse for me being able to be called a nurse, and I absolutely better get out of teaching. Because if what I just did was to teach somebody how to do something wrong, I am a total loser. And these were nice words that I was calling myself. I shamed and blamed. I lived with shame and blame for an incredible amount of time and really saw it as my fault. I was careless. How could I have missed the fact that we did everything right but give the right medication. And I put up a wall of silence around me. It was real easy to do it because no one was doing checks and balances, but I could not talk about this with anyone. And now, as I look at where I am 3 decades later, which is kind of ironic at the National Patient Safety Foundation, here are some things that I wish was on my mind at the time. Okay, and these are some of the things I think we really want to focus in on helping our faculty and our students understand. Number one, what was the emotional patient harm that occurred to an adolescent with cystic fibrosis who knew every single detail about his care and knew that I had royally screwed up? And he goes in once a month to get cleaned out, and what happened? He gets the wrong medication. There's clearly emotional harm that is happening, regardless of whether or not that patient had any physical harm. I wished I understood how to do a great root cause analysis, an action plan, a strong action plan. You know what my action plan was with my conversation with the nurse manager was, don't do this again. That was the action plan. I had no action plan in my school of nursing because, quite frankly, I told one person and there was never any guidance on what I could be doing differently to prevent that from happening. I wish I understood about systems issues, and I'll tell you why in a minute. I wish I had known how to apologize and disclose what I did with some sophistication. In fact, I did apologize to that patient. I don't think that I did a very good job of truly apologizing and understanding what that looks like. In an environment now where we have communication and resolution and programs, I could have been doing a whole lot better. I wasn't thinking about preventing future harm. I was thinking about me not preventing any future harm, but I wasn't thinking about it in the context that I could have and should have been doing. I wasn't sharing, okay? One of the most important ways we learn is that we share. I was too blamed and shamed and just so disgusted with myself that I could not talk about it. I wish that what was on my mind was that I would have known or could have thought of that I needed peer support, that I needed support at some time, because I think at that point in time, I was really depressed and probably didn't know that. And we're going to talk about that with our workforce today. I wish I could have been a role model for wrongness, on how to be wrong and how to positively be wrong and turn things that don't go well into things that can go right or can go differently. I wished I had had some help and guidance on how to move on, and this is the kind of stuff we're doing a whole lot of work with right now. And I wished, and this is the one that burns me all the time, is, well, I remember talking to my student briefly. I worry about what the impact of that was on my student. And if you're in this room today, I apologize to you because I know that I was more concerned with myself when what I know now is that I should have been concerned with a whole lot more things. So speaking of root cause analysis, which, by the way, I couldn't really do until 3 decades later. That's how embarrassed and shamed I was for what had happening, and this work at NPSF helped me do it. I was working 2 full-time jobs. I was teaching full-time. I was a new faculty member, so I'd get, okay, here's the 11 courses you're going to teach the first semester, and I'm working full-time, 12-hour shifts, often doing nights in an ICU, and I was working way beyond my human limits. I was fatigued. We heard this earlier. A nurse who works more than 12 hours and 30 minutes is 2 to 3 times more likely to make a medication error. There's an abundant amount of research on fatigue and the impact on cognition, and not only harm to patients and families, but also harm to the workforce. And the other thing that you just saw on the slide, Carol, thanks for setting me up so well for this talk, is that the Swiss cheese model is so very real. And at the sharp end of the error, which was me, there were really a lot of systems issues that were in play and human factors issues in play with look-alike, sound-alike medications, for example. Systems issues. No one cared how many jobs I was working. No one really cared that there were 2 full-time jobs, that I was going 24, 36 hours without sleeping. I was invulnerable. I was young. I didn't know that I had to be worried about that. And that to me is a personal issue, but is a huge systems issue. And we've talked about that this week. And I also know that accident investigation, which really didn't happen other than that incident report that I filled out, is still a huge problem. We do not have reporting systems that are adequate. We do not teach faculty how to teach students how to do adequate reporting. And we don't learn from those reporting systems. We don't share. We stop when we think, oh, here's the one root cause of what happened. And someone the other day said, we got to keep questioning. Why? The action hierarchy for improvement plans is something that has become so much more sophisticated. We actually have a great report on our website. It's the RCA Squared report that I encourage you all to read and look at as you think about how to integrate accident investigation, for lack of a better word, into your curriculum. And the other thing that I realized was that I hadn't been able to put in perspective all of the times that I had given medications safely. And I hadn't learned from the things that had gone well. And one thing that I would challenge you to think about is, as you work with students on how to do root cause analysis and develop strong action plans, more than just try harder or do better, but is also to do an RCA on what is going well. Kind of innovative, but we're starting to see this happen. I also learned the trajectory of harm can be long-term, and I actually was sitting on an ARC emotional harm task force. Sue Sheridan and Helen Haskell were in the room, and we talked about the fact that emotional harm in particular is not just a time-limited sense of harm, and that peer support is critical. So let's talk for a minute about the Hippocratic Oath. I'm connecting a whole bunch of diverse dots here. How many in the room have not heard of the Hippocratic Oath? Okay, we've all heard about it. What are the words that you know that are in the Hippocratic Oath that link to the work that we're doing here? First, do no harm. Everyone in the room agree, first, do no harm? Okay, you see the heads all shaking. The Hippocratic Oath, which was developed quite some time ago, is really interesting to study. And first, do no harm is what you'll see virtually every seminal report and publication on patient safety start with. First, do no harm. Primum non nocere, or something like that. I took 8 years of Latin, so hopefully I'm close. What I really hate to burst your bubble before you leave this meeting today, but the words first do no harm are not actually in the Hippocratic Oath. They are not. This is true. This is not like fake news of any kind. What's in the Hippocratic Oath are a bunch of really interesting things, which I thought many of you are faculty, you would appreciate. Now, the Hippocratic Oath was done when doctors who were all men were teaching up-and-coming doctors who were all men about what to do. And it's the honor code that they took. And the Hippocratic Oath actually includes language that says a few things. I am going to hold him who has taught me as equal to my parents. That is how vitally regarded the role of the teacher was in the Hippocratic Oath. This is a great one. I'll give him a share of my money if he is in need of it. Don't you kind of wish when you see the tuition dollars flow into your organizations and you look at your salary, you would think like, okay, sometimes we might be in need of a little bit of help, but have you ever heard of that happening? No. The Hippocratic Oath says, I'll also expand my family because I'm going to regard my teacher's offspring as equal to my brothers. That's how close the whole practice of medicine was at the time. I will neither give nor suggest a deadly drug. I will remain free of all intentional injustice and mischief. That includes not fraternizing with the patients, okay? If you read it in detail. And here's HIPAA 1.0, okay? We had to legalize HIPAA, but in the Hippocratic Oath, it actually says, I will keep what I see or hear to myself. We have laws about this that actually prevent people who need to and have the right to know about what's going on with patients from not being able to know and understand that, because the HIPAA says I can't tell you anything even if you're my healthcare proxy, or because your kids turn 18 and you have no right to any information about what's going on. It does say I will keep patients, the sick, from harm and injustice. And in the corpus of work of Hippocrates, there is discussion about harm. What it mostly says, if you can't help, at least do no harm. And it wasn't until the 1800s that the English Hippocrates, Thomas Sydenham, actually contextualized the phrase, first do no harm. So I just thought, I always like to add some trivia and perspective, because we let a lot of this legendary stuff continue to drive what we think and what we know. I'm not saying first do no harm should not be the first thing on our mind, but a little background information on that. Now, I want to connect some thoughts on the dots that I've heard today. This is my job. I'm getting to it a little bit late, I know. I want to talk a little bit about academic programs, transition into practice, the established professional, and also mastery level stuff. But some of what I'm going to talk about relates to all of those dots. So don't consider these connecting of dots to just be fixed into one single dot. Let's start out with academic programs. All teach, all learn is something that I think many of us take to heart. This is one of our main values at the Institute for Healthcare Improvement. I would encourage you to help yourselves and your students think about this as all teach, all learn, all the time. It doesn't stop when the class ends. It doesn't stop when clinical ends. It doesn't stop when students are doing extracurricular activities of any kind. It doesn't stop when they go into practice. I love the focus on experiential and interprofessional learning. And I also want to add in this concept of bidirectional learning, because we can learn so much from our students who ask some of the most obvious questions that we don't think to ask, because we've been kind of doing things the same way for a whole long time. One of the things I hear as I travel really around the country and the world is that there are a lot of faculty, not just in nursing, but in nursing as well as medical education and others, that don't feel comfortable with quality and safety education. I'm doubting that's you who are in the room here today, but you probably go back and you have peers who never really have gotten into this. Most of us were never educated on this in our undergraduate programs, and I would encourage you to, if you've got somebody who's really not into this, let's start thinking about ways to bring everybody on board. Because what our students can't have is a discrepancy between what the experts and the choir is preaching in this room, and then go to another faculty member who's just not totally into it. Workforce wellness and safety is something that I believe must be more thoroughly engaged into academic programs from the get-go. The work we've done at the National Patient Safety Foundation and all of the work that's out there has concluded that workforce safety is absolutely preconditional to patient safety, and yet we don't really teach our students all that much about how to keep themselves well, how to keep themselves safe. And in fact, we have a workforce right now, quite frankly, that is composed of, me, look at me. I used to be the patient, like when I graduated from nursing school, that people would look at and worry about. And we spend, for one example, so much of our time on slips, trips, and falls. We heard about the dangerousness of the healthcare workforce. We are the third most dangerous industry according to OSHA statistics. And isn't it ironic that one of our biggest areas of harm are slips, trips, and falls? The same things that we focus in on for our patients, we don't think about for ourselves. And the other thing I'll just round out this brief academic perspective with is we talk about handoffs of patients, and we heard about handoffs of patients when Carol spoke. But you are preparing our nurses for the ultimate handoffs in their career. And understanding handoff safety and expertise, I think, is absolutely vital. And as we transition people into practice, we're seeing a lot of people that are not staying in nursing. They're changing jobs, they're dropping out, all of these amazing, wonderful colleagues that we could have because they're having lousy handoffs. And many of you, and I love seeing QSEN expand throughout that whole professional trajectory because I think it's a really critical connection point that we have to make. We need new ways of thinking about how to sustain habitual excellence and how to build resiliency. And we know that if we throw a student out into a setting as a newly licensed nurse, and in 15 seconds they have a bad interaction and a lousy culture with somebody who's not professionally behaving all that well, otherwise known as disruptive, we can destroy everything that we have built in seconds because of that. I'm going to come back to this in just a little bit. Now let's talk about some other workforce wellness issues. If you take a look at this slide here, I know you can read the words. I want you to look at the body language of people that are not even waiting in line to go to the restroom. These are people who can't even get to the restroom. And the workforce, the attention to the workforce health in our systems right now is really in severe need of improvement and course correction. This is a nursing protocol for bathroom breaks. Are you a nurse? No, if you're not, you can go pee. And if you are, there's a whole bunch of other things that you have to do before you can go pee. Never mind eat. And look at how the eyes light up when someone brings in donuts and cake and all of this unhealthy type of food to the nurse's station. And I see this all the time. I was just a patient in an ED. I was a Gomer, one of those get out of my emergency room patients. If you've read the House of God book, I'll tell you a story about that some other time. But I watched. I had a hallway bed right at the nurse's station. I could see the whiteboard. They had no idea I was a nurse. And I was having the time of my life, watching what was going on, but also watching how people were eating and what they were eating. And boy, was that not like a wake-up call to what we need to be doing differently. And I know this is not what Maslow was thinking. We teach the hierarchy of needs in all of our programs. But he wasn't thinking that the really important folks that are out there on the front lines of care were not even having their basic biological needs or concerns for nutrition, for rest, for real restorative rest and sleep being addressed. We've got some nice work on our website on through the eyes of the workforce, creating joy and meaning in a safer healthcare workforce. And so what's all of this doing? It's putting a lot of us out of order. We've got unprecedented amounts of burnout, lost work hours, as I talked about attrition, we've got difficulty with retention. Anytime we've got people who are not at their best, we have less vigilance with safety practices. Miscare we heard about the other day. Miscare is not just miscare. Miscare is a preventable healthcare error, period. And that is how we need to treat and address missed care. Workforce physical and emotional health harm and decline are, again, at unprecedented rates. How many of you who know, don't answer this personally, how many of you who know nurses who are depressed? Okay, slowly, just about all the hands in the room go up. We have rates of depression, we have rates of suicide in healthcare that are really climbing in ways that are absolutely frightening, and moral distress. I've been honored. I serve on the American Nurses Association Steering Committee on Moral Resiliency, and we're doing what I think is going to be some really important work that we hope to get out soon. When we think about things like workforce injuries, slips, trips, falls, musculoskeletal injuries, or we think about the state of our workforce, which has a lot of chronic disease in it. Most of us have some type of a disease that's chronic. It might be asthma, it could be obesity, it could be that we're depressed, it could be we have COPD or heart disease. If you look, how many of you talk to your occupational health colleagues? Okay, well, I'm actually surprised that 3 hands in the room went up. Great for the 3 of you. And please, when you think about the things you can be doing, is to pay attention to your occupational health colleagues and also the literature. When people get hurt at work or when they go to work and they have diseases, there are obviously pharmaceutical costs and medical costs that are associated with their care. However, the cost associated with absenteeism and presenteeism in terms of lost productivity are exponentially higher than the physical care, the medical care, or pharmaceutical care that someone with such a condition will receive. Now, people will ask me, what is presenteeism? They kind of come up at the end and they say, what did you mean about presenteeism? So I'm just going to say it. Presenteeism is when you show up for work. It's not that you go and you play Angry Birds all day. You show up for work and you can't give it 100%. And there are so many times when I am most presenteeism and when I've been most suffering from presenteeism in the last 12 years, it's when my kids' college tuition bills have come in. And I've had to figure out how to juggle money from one account to another. And so it's not even really crazy stuff per se, but that's on the minds of all of us, and I know all of you, and I hope a lot of your kids have been able to get college educations where you teach. That was one of my goals when I was teaching, because boy, it's pretty darn expensive. We heard a lot about undoing versus being, and Carol talked about going from noticing to doing. And what I'm going to use in the context of doing is that we are just doing all the time. We are doing so many things. We don't even know why we're doing things anymore. Most of the time it's because people are telling us we have to, the regulators, the payers, etc. But this whole concept of taking our colleagues from feeling like they're just doing stuff to being and enjoying the jobs that they are doing and having meaning in their work is absolutely critical. And supporting our healthcare workforce, we have a lot of this in the report that I referred to earlier. I want to point out the 3 R's: respect, recognition, and resources. Paul O'Neill, who was the former chair and CEO of Alcoa and served as the secretary to the treasurer under George Bush, was on our Lucian Leib Institute. And when he took over the helm of Alcoa, he's the first outside CEO they hired. Very, very scary, because they'd been a company that was over 100 years old. All the finance world wanted to know, what are you going to do for Alcoa? And he simply said, I'm going to make Alcoa the safest company in the world to work for. Financial community went crazy. They said, come on, answer these financial questions. And Paul said, I don't think you understand what I just said. I'm going to make Alcoa the safest company in the world to work for. And he has 3 questions that he said, every single day when you come to work, you must be able to affirmatively answer to the fact that you feel respected by everybody that you work with, that you are recognized for what you do, and you have the resources to do your job. Boils down to something as simple as that. And the people that decided not to, they removed their assets from Alcoa, were really upset with themselves because Alcoa became incredibly profitable as a result of this one core approach to managing work. Now, we've talked about IPEC. We've got some great work going on in the National Collaborative for Improving the Clinical Learning Environment. NCCL is what we call it. It was started by the American College of Graduate Medical Education, and it was really to help improve the clinical learning environment for med students and residents. And they have created a new learner task force. This is for the early practitioner and we've co-sponsored this work with them that is looking at what are the competencies that people should be able to demonstrate in safety from the time they get licensed over that first year of practice. And we're thrilled to have Joanne Dish be our representative from NPSF on this committee. This is work that is going to be, I think, really important to think about integrating in the future. A few more comments on DOTS culture. Lucian has said repeatedly the single biggest reasons why we're not making progress in safety is we continue to punish people for making mistakes. And we are, in fact, hardwired to remember the wrong. We all want to know, well, what happened and who did it, right? And, you know, those kinds of questions are not necessarily the most helpful questions to ask, even though we are culturally, and Catherine Schultz from Harvard says, you know, if it's sweet to always be right, let's just acknowledge it's downright savory to point out that someone else is wrong. She's got some great work on wrongness that I mentioned earlier. And if you look at the bottom, this is the survey of patient safety cultures. How many of you teach survey of patient safety cultures in your programs? Okay, I'm going to put this on your immediate to-do list. I would like you to get more familiar. The Agency for Healthcare Research and Quality has surveys of patient safety culture. They are not mandatory. I believe they should be. And they ask employees to rate the safety cultures within their organizations down to the unit level. And consistently, in all the comparative databases of hundreds of hospitals and nursing homes and everything else, the single most poorly rated issue in this patient safety culture stuff is a non-punitive response to error. This is the world you are injecting your students into, and this is the reality of what is going on out there. Happy offline to talk more about that. We've talked a little bit about just culture. I'm disappointed that not every state board of nursing is using a just culture framework for how they address issues. I'm also disappointed that we don't have healthcare delivery organizations that are not consistently using the just culture framework. I'll move on from here because I want to talk about leadership. Leadership is not in the QSEN competencies. I happen to be, we had a great brainstorming session last night. I happen to be a very firm believer that leadership has a place in the QSEN competencies. And there's a lot of reasons why. They have nothing to do with whether or not somebody is in a formal leadership role. This little chubbabub in the photo that you see here is actually my baby, who graduated a week and a half ago on the 4-year plan. It was one of the most meaningful miracles that's happened in my life. From Bryant University, and you go and you sit there for hours. You all do this because you're all at these events. You sit there for hours waiting for the processional, and you get to tweet now, right? I don't know if you see this, but so his 2 big sisters, give me this picture of Michael. This is only a couple of months after he was born. He weighed 10 pounds when he was born. I didn't know you could break a pelvis giving birth, but I did. So I'm now prepared for when I break a pelvis as an elderly patient. I want you to know I know how to use the walker. So they sent this picture and they said, tweet this, Mom. And the tweet was, does frat president count? I couldn't be more proud of him. He's not a formal leader. He's got incredible innate leadership capabilities that I failed to appreciate over many years of trying to just get him the heck through college in 4 years, but an awesome, awesome person. And then when we look at mastery, I'm going to not spend much time on this because I'm going to skip a little bit more to a few other things. There are also some other areas to think about. We just published this paper. This was a survey that was intended to inform our work, which you should never really just do a survey without hoping that it gets published. And so the Joint Commission Journal on Quality and Safety finally published it in print this week. We asked CEOs, board members, and we also asked safety, quality, risk leaders, and non-CEO executives to rate themselves on safety. So the CEOs and board members self-reported their activities, knowledge, and understanding with respect to safety and quality. And then the safety, quality, and risk leaders reported what they thought their board members knew and did with respect to safety and quality. Total convenience survey. I was so happy the other day when I heard, don't worry about p-values because it's not statistically rigorous. It was not meant to be. But let me just point out a couple of things for you. It might be a little hard to see. I'm going to particularly point out the CEO column. CEOs self-reported on that second line that first line, only 61% of CEOs said, we review a patient safety and quality dashboard at every board meeting. And only 8% said, we review a workforce safety dashboard at every board meeting. I see no reason why any organization that receives accreditation should not require boards to look at dashboards on quality and safety, not only for patients, but for their workforce. And that's one of our dreams and one of our goals at NPSF. We just published this blueprint a week ago at our annual meeting. We created a guide for CEOs to help create a blueprint for their organizations on cultures of safety. There's actually very practical recommendations in this report, so I encourage you to download it because there's some things there that I think are helpful. We talk a lot about students going out into the real world, and we talk about them getting jobs and placements. I think there's a whole lot more we need to do from a hiring manager perspective and from an interview candidate perspective. And on this list, I'm just going to bring out one thing. If I were a nurse manager, I would want to be able to say, these are my survey of patient safety culture report scores on my unit. Here's where we're doing well. Here's areas where we're not doing so well. But here are our plans for how to address those areas. And if I were a student right now going in to take a job, I would teach them to ask that question. Do you do surveys of patient safety culture? And I'm working on a framework for this with a whole bunch of questions I'll be happy to share with you down the road. If you go on an interview as a student and you don't have a nurse manager or a hiring manager that can answer these questions, you know what I tell people now? Go look somewhere else. Because it's inexcusable that we cannot translate line of sight and real metrics around where we stand with our cultures of safety. And patient safety now at a mastery level is considered a specialty. It's also considered, again, a core competency for all of us. As you heard when I was introduced, we now have certified professionals in patient safety. We've got a couple in the room right now, I know. Raise your hands. Where'd they go? They're on their planes. Okay. All right. So I'm going to finish up now with a closing story. I've already gotten the signal that I have just a couple minutes left. This is a real story. Like I said, we get a lot of them all the time. So a 25-year-old female wakes up feeling sick one day. She counsels high-risk adolescents is what her job is. Pretty kind of important contributor to our society. And she calls her primary care physician after a few hours for an appointment. Minutes later, calls 911 because something bad is going wrong. She's transported to the local ED. Her evaluation included a septic workup. I know you're hearing sepsis for the second time in 2 hours. They transported this young woman to an ICU of a teaching hospital. And the very first day that the person was in this hospital, guess what was going on? A big bang, go live of a new, I hate that, electronic health record. I hate when that happens, don't you? Autocorrect sometimes. Big bang, go live health record. This young woman is ventilated. She's on 6 strips. She's failing dialysis because she keeps clotting off her catheters, but she's conscious and able to interact with her family and her team members for 2 days. If it was me, I would have been dead before I made it into the ICU. But this is the resiliency of youth. Her decline continued over the next 4 days. She was unresponsive. Family was told perfusion's compromised, we're going to need a below-the-elbow amputation. And her perfusion continues to deteriorate. Her skin starts sloughing. She's transferred to a burn unit, and she gets to the burn unit, and Carol, you know, this is just like so linked into the story you told. At best, quadruple amputation, but likely not good brain function. So this patient's family has to make a decision. They decide to transition to to comfort care, and she dies on day 7, surrounded by her family. And I wanted to tell you this story because this is actually a story about a patient. This happened 2 years ago. This was my amazing, beautiful 25-year-old niece. And I was at the bedside from the get-go. We all get called, the 911s that we get when someone's in the hospital. So I spent 7 days, basically in 3 hospitals, watching this happen. I have a few final thoughts that I just want to share about the experience. Number one, you know, we looked at that 99.9% number this morning. I want to tell you that not all healthcare stories that you hear are bad stories. This was a very unfortunate outcome, but I have to tell you, and first of all, if you're like a nurse at a bedside and you've got anyone who's a nurse, a doctor, or a lawyer in the family, you just want to like go home. But when you have somebody who is you know, working at the National Patient Safety Foundation, that's not a great feeling, I'm sure, for many nurses. I had the most incredible experience. I worked in sepsis research for many years. I called all the sepsis research, as I know. They were doing exactly everything they could. They were going live with the EHR that night. We all know, and we look at that as a major safety risk in healthcare when you transition EHRs. I was so worried about what was happening. This team said to me, this is going to be good for us. Most teams don't tell you that. When they hear EHRs, they swear. To a person, they said, here is what our backup plan is for your niece, because she was triple teamed at this time. And here is the entire backup plan. I want you to know this because I know it's important to you. There were people caring for her that were her age. The person who came out and told us in the burn ICU that it would be a quadruple amputation at best was a very young nurse. She was the most courageous nurse I have ever seen that told my in-laws that it's not just a below-the-elbow amp. It's a quadruple amputation at best. That to me is leadership, that is courage. These are the kinds of things that are so critical for care. And I would like to tell you that I think we are in the 99.9% group because all of our care was amazing, particularly making the unbearable bearable. And I have to tell you that to me, this is what safety is about. This is what quality is about. This is what we are about. And the kinds of things that we teach, which are mostly around mortality, absolutely vital, major complications, absolutely vital. I have to tell you that sometimes you just, like 3 decades later, look through the lens of healthcare and you see all of the amazing things that do happen even under the worst of conditions. And I am so very grateful for the care that we had. So you're leaving here today. By the way, that story was to give you a few more dots to think about. I hope you can connect the dots when you think about this journey, the freedom from harm. I'm grateful for all that you do. I wish I was still with you. Really, why I'm not teaching anymore is because that mistake that I actually made, but I feel like I'm with you. And I'm grateful for all that you do. And by the way, Google just published the most commonly misspelled words in our country. Came out today. We got this pen sent to us a year ago, and this is a tchotchke. They want you to buy pens. It's the National Patient Safety Foundation. I have no more patience. I am trying to channel my patience, my impatience productively. And Oklahoma, I want you to know, if you're from Oklahoma, patient is the word that was most commonly looked up as a misspelled word in Google searches, which I found a little surprising. I don't know if they're talking about patience, like we take care of, or just being patient. And pneumonia came up a whole bunch of times too. So it has been my joy and pleasure to work with you. I think we're really right at the end. We probably don't have time for questions. I'm looking at you, Pat, and the answer is no. I'm here for a little bit. If you do have any, you know how to get a hold of me at the National Patient Safety Foundation at the Institute of Healthcare Improvement. And I'm grateful for letting you share my perspectives and my stories. Thank you.